Good morning. Welcome to the Informatics PowerTalk series. This is the second talk this year, and actually the first talk from outside speaker this year. We're very happy to have Professor Tapan Mehta to give us a talk. Dr. Mehta is a professor and vice chair for research in the Department of Family and Community Medicine at UAB. He had training in biostatistics and electrical computer engineering. Currently, he leads several NIH research centers. One of them is Nutrition Obesity Research Center, Behavioral Science, and the other is the analysis core of the Data Coordination Center for National Center for Health, Physical Activity and Disability. So he's very well published with more than 70 peer-reviewed articles related to telehealth, family medicine. His interests span from clinical, epidemiological, and health services related to obesity, metabolic disorders, disability rehabilitation. He's certainly an expert that will provide us with fresh perspective in this department, and I believe that is the first speaker who will share with us experience from this department. Without further ado, let's really welcome Professor Mehta.
Thank you, Dr. Chen. Thanks a lot for the invitation, and thanks a lot to Dr. Wang and Dr. Semino as well for helping and organizing this. So today I'm going to go through some completed and a lot of ongoing work around projects that align with Quintuple Aim in primary care. As Dr. Chen described, I am an engineer, also a biostatistician, and evolved as a health services researcher with my data science background. I try to bring study designs, informatics, and the application of AI/ML in our ongoing projects. So let me start with acknowledgements. A lot of work that I'll be presenting is work that has been due to collaborations through different centers, and some of the key folks have been listed over here, but just wanted to say this is a very team science approach we have for us to be able to address this major challenge, at the same time utilize the opportunity to bring this innovation from both pragmatic study designs and combine it with informatics and AI/ML. So I think I want to thank all of the folks who have been participating with me in the projects we are working. This is a disclosure around my consulting agreements. So let me start with the Quintuple Aim piece first. Quintuple Aim got introduced very recently. It is an extension of the Quadruple Aim, which focuses on improving patient experience, improving population health, reducing healthcare costs, improving provider experience, but now also focusing on health equity. And I think the why part for me in primary care and family and community medicine is very important. These maps tell you some story here that we are in Deep South. We have one of the highest cardiovascular death rates, one of the highest obesity, hypertension, diabetes, related rates. We also have a significant shortage in primary care workforce, and for us to be able to really manage population, improve population health of our communities, of our state, it becomes important to sort of think about what resources we have, how do we bring our programs, interventions that can increase the reach and increase the effectiveness. So I think that's sort of the underlying theme of my ongoing research, uh, you know, and I thought that it's important to set the context before we get into some of the projects. From a health equity point of view, the focus is on racial health inequity, disability related inequity. Uh, as Dr. Chen mentioned, I'm lead the data coordinating center in NICPAD, and I'll present some work around that. And then also urban, underserved, and rural, so the geographical areas. And then you combine them. So there is an intersectionality of race, disability, racial disparities, disability related disparities, rural disparities that propagate into health inequities. And that, when you combine with a primary care workforce shortage, sort of we need to think about how we can innovate and really improve our ability to serve our communities. So what I propose here in next, you know, 45 minutes or so is to discuss some pragmatic effectiveness and implementation science studies, some improvement science approach for a learning health system in primary care, and how informatics and AI, ML related work can get integrated in these, and actually uh, can also be enhanced by the ongoing pragmatic studies that we are doing. So I'll be giving you some examples and some ongoing work that we have around this area. Let me start with the first, uh, uh, sort of study that really helped me transition and think about health services research in a very different way. This is the tele-exercise and multiple sclerosis study. We finished, wrapped up this just a month or two ago. It's a PCORI funded study, a pragmatic cluster randomized comparative effectiveness trial. And the really the central theme of this project was that there was a lack of evidence-based exercise programs for people with MS, and actually this is applicable to people with stroke, people with other functional limitations, that a lack of access to these uh, specialized exercise programs. And there were only one or two centers. One of them is Tanner Center at Homewood, which had some specialized ability to provide this in an ambulatory setting. However, patients had to drive all the way from Alabama, like different parts of Alabama, Mississippi, to really get to it. So the idea was to really see if we can build a tele rehabilitation or tele exercise program with minimal implementation barriers. And the way we proposed this was to use integrated voice response and then also exercise videos in offline mode. So really thinking about the reach and being able to offer this exercise program in an asynchronous way, and also keep our participants and our members who join the program in touch. So it was trying to address any internet related gap that may have, because if video bandwidth is required, then that would exclude you know participants who would otherwise benefit. And also we kept away from an app, a phone-based app. This was back in 2016. We had proposed actually, but the idea was to not really have a phone-based app, but really something that could be delivered through a regular uh, phone service, including cell phone, but also landline. And also looking at immediate and sustained effects of exercise and rehabilitation. So the program was a 3-month program. That was what was delivered at the Tanner Center on site, and we propose to do that both through a clinic-based therapist-delivered approach, which is we call as direct cam on site, and also telecam, which is an asynchronous tablet asynchronous approach where videos have been loaded on tablets, and that's coupled with the IVR call. We were looking at two sort of the immediate effect at 3 months right after the program ends, and then sustained effect, which is do these effects get sustained, uh, and really focusing on physical activity, pain, quality of life, fatigue as our key outcomes from a patient reported point of view. In terms of so it involved setting up of some infrastructure to really get this going. So we had uh, we had programmed the integrated voice response to really get integrated with RedCap. Also customized who was calling, made it culturally tailored so that it sounded like a person from a community could recognize. So it didn't sound like a robotic voice, uh, as well as feedback that was provided by the participants through this IVR call. We also provided them some feedback. So there was an engagement mechanism when we did this back then. When we had implemented a few years ago, it was a rule-based approach, but it was a fairly detailed approach to provide feedback on goal setting and outcome expectation and how they were doing based on their responses, and then developing a dashboard where we were tracking their adherence for these IVR sessions. And this was specifically for the telecam group. A brief note on like pragmatic study design principle. The idea was to have something that is real world, has broad that is applicable to broader population, very generalizable, and the data collection and participant burden is minimized. So we were actually able to implement this. You'll see in the next few slides, like across 43 clinics in Alabama, Mississippi, and Tennessee. Really good participation, and we thought about this research intervention. Basically, we were comparing the delivery of the intervention. Both groups were getting interventions, uh, so it was more as a line of treatment, research as a line of treatment for the clinics and the populations. And uh, so that was an important thing for us to think about, the pragmatic piece of it. Really included the stakeholders to make the design pragmatic, understand which outcomes were required, even for the integrated voice response scripts, cause a lot of usability testing that we did. Uh, there was on the tablet, there was an app for the preloaded videos that we also had usability testing done. So a lot of engagement from the stakeholders to really help our study make really pragmatic and really achieve our goals. So the assessments were patient-reported outcomes were fatigue, physical activity, pain, quality of life. We were also looking at some clinical outcomes around balance, gait, endurance, strength. And then we were also interested in tracking psychosocial outcomes, largely for the telecam group. These were being tracked and intervention provided through the IVR calls. So this is just an overview. We had biweekly IVR calls for the first 3 months, and then uh, actually weekly IVR calls for the first 3 months, and then biweekly IVR calls from 6 months to 12 months. Uh, the comparison was between direct cam and telecam, and our main endpoints were at 3 months and 12 months. We wanted to look at both immediate and sustained effects. From a inclusion exclusion criteria, we kept it pretty broad, uh, and the idea was to recruit from the clinics, utilize support groups that we could do, because we had tablets with preloaded videos, and in this patient population there are support groups in local areas. We decided to use a cluster randomized trial and not an individual randomized trial. And there are some challenges in implementing trial, but I think largely we were very successful. I would say the only exclusion criteria I would remove if I had to do this again is we had an exclusion criteria of already meeting physical activity guidelines, which I would have avoided if uh, we redo this trial again. Yeah. So we recruited uh, 382 participants in the telecam group and 377 in direct cam group. And I would say that this is one of the first large studies. The pragmatic aspect of it reflects in the fact that we had about 25% of our population of sample, Black adults who have MS, which is not typically observed in these smaller studies, very tightly controlled studies that have been published. Similarly, we had about over 20% of our population coming from either micropolitan or rural areas, so really non-urban areas. That was sort of another win. We would have liked to have it more, but that still shows the fact that it was really reaching a wide spectrum of the patient population. And this is sort of the reach of our study across Mississippi, Alabama, Tennessee. We had participants who were interested from Georgia, Virginia. Actually, PCORI had asked us not to expand further because they had some criteria around which states we could have our trial operationalized. This is distribution of uh, distribution of participants from different sites. So we had physical therapy clinics in different areas recruiting patients, and you can see some of them were in non-urban setting, and a fairly similar distribution like Birmingham and Montgomery showing high, recruitment numbers. But again, very focused approach to really build recruitment across these sites. I'm presenting these results. These results are very new. We just submitted the PCORI report. So this is, sort of fun to just present you all what we found. What we found was that at 3 months, direct cam was beneficial, was superior to telecam, which is an asynchronous version. Direct cam is again participants are going to the clinics and having in-person exercise training, whereas the telecam is completely asynchronous. What we found was that in the average treatment effect, on average, the SF36 mental component score was the only one where we found that direct cam was superior to telecam at 3 months, and then one can see that at 12 months, actually, there is really no difference between these two groups, which was very interesting. And then if you look at further in terms of the objective outcomes, the walking performance measures that were being assessed, 6-minute walk test was superior compared to in direct cam compared to telecam. But again, that difference really shrunk at 12 months. So while in-person training, in-person delivery helped at 3 months for one of the clinical outcomes and one of the patient-reported outcomes, there wasn't really, for other. There was in addition to this, there was Berg balance scale where I think there was clear benefit of having a direct cam approach and which got sustained, but everything else sort of showed no difference, or the difference shrunk at 12 months. So we also looked at what happened within each group, within each arm, within telecam and within direct cam. And what you find is, what we are finding is interesting, that both groups increased direct cam increased more in some areas such as 6-minute walk test and Berg balance scale, and but there is improvement also in telecam. Uh, so when you look at the 3-month mark, for some measures, we find direct cam is superior, but at 12 months, the difference, the benefit of being in direct cam actually goes away, and the sustained telecam that somebody has videos, tablets, they can do these exercises regularly. That effect tends to be, be sustained longer than a direct cam would be there. So to summarize, I think there were improvements in telecam as well. So, and you could see that there were also like clinically meaningful changes that we actually found in these groups. So the next part then, for us was to like, okay, how can we build on these pragmatic trial data? Like, how can we make this more pragmatic, more sustainable? And so this is an example of a waterfall plot where we can look at who benefited, which patients, which participants benefited from within the telecam arm versus those who did not benefit from and this uh, indicates that there is sort of heterogeneity of treatment effect that is playing out here. So it's not like telecam individuals do not benefit at all. Like there are some who have benefited significantly, while there are some who haven't. And I think that will lead to some next designs and how we use these data in next couple of slides. So uh, based on that heterogeneity of treatment effect, we started looking at, can we use these IVR data, psychosocial data, baseline demographic data? We had some zip code level data. Like, can we use it to predict physical activity outcomes and build a prediction algorithm to say, okay, which measures will yield a better timed and up and go outcome for telecam patients and participants, and for 6-minute walk test. So these are just examples, but we started using machine learning techniques to really train our models and then predict which ones are showing up as important predictors over here. And that is and another example over here is predicting adherence to remote exercise programming. So now we are not focused only on the average treatment effect. Now we are building upon how do we harness the heterogeneity that we are seeing uh, in really improving and sustaining our and building a much more refined way to deliver this program. So for some people, telecam does benefit. Who are those people? What are the factors that we can use to sort of predict? And that's an exercise we again went through uh, and a further refining to improve the predictive accuracy of these models. But that's, I think, the important part over here is to really think about the trial providing data now, especially if it's a truly pragmatic and we are able to collect a lot of the remote data using IVR or wearable data, then we are able to now build these models where we can predict about outcomes and further develop adaptive interventions. So that takes me to the next step about developing now pragmatic optimized interventions. And from pragmatic interventions to optimized interventions. And it goes back to the theme of like we have a shortage in workforce, we have several health issues in our state, in our community. So how do we really, develop programs, develop interventions that can be delivered in a way that only those who require more resources, get those interventions, whereas the ones where we can work with a low cost approach, those interventions could be utilized for people who are responding to these low cost interventions. So one of the areas of my several studies that I have got funded and then we have supported through our course get implemented is the multi-phase optimization strategy. It's a framework that Linda Collins and others have advocated. Really uses some engineering principles, but the idea is there are three phases: a preparatory phase, an optimization phase, and an evaluation phase. And the preparatory phase is to really identify intervention components that may be useful, identify some optimization criteria that could be then subsequently used in an optimization trial. The salient feature of an optimization trial is that we are trying to not test like a package in itself in a trial. We are trying to look at different intervention components and either build an intervention package or I would say even like de-implement an intervention package. So we'll go through some examples, but that optimization phase requires an optimization criteria. It requires, and that work needs to be done in the preparatory phase. This framework, it's sort of useful also because it provides a way to do these studies in a very resource efficient manner. So if we had to try these things out as traditional randomized control trial, we would require far larger sample sizes, whereas these optimization trial designs allow us to do it in a very resource friendly manner. And once we have an optimized intervention identified or sort of ranked 2 or 3 different optimization intervention packages we want to compare, then one can do a much more confirmatory trial to really look at these things. So the most preparation phase has important aspects, identify intervention components, identify optimization criteria, and then tailoring variables for adaptive interventions. From an optimization design, the 2 designs that we have focused in our team and supported other groups, implement those are developing programs that are optimized on average for the population. These are factorial experimentation, and the table on the right about combinations of intervention components is an example, and we'll go through that because it's one of our studies that got funded. And then the other design is called the sequential multiple assignment randomized trial. So factorial experimentation allows us to optimize programs on an average for the population, whereas smart trials are trials that are useful to optimize programs, interventions to by factoring the heterogeneity of treatment effects, the individual level responses. And so the idea is that there is a non-responder. If somebody is a non-responder to a treatment, then we can re-randomize them to other components. And how we build that non-responder, like that criteria, decision rule, is where we are now starting to implement machine learning based approaches using pragmatic trial data. So again, just an example over here of like we have a non-responder, and typically a non-responder could be a blood pressure value or A1C value. But however, we are moving now more towards using EMR data that could be used to predict whether this person is going to be a non-responder or a responder, and then go and use that as an approach. So one approach over here that we did pilot with my colleague Jeremy Wilroy who built upon one of our R01 studies is to really look at, and again, an exercise program where participants are randomized if they do not meet a certain criteria of video minutes. Back when we did this, we had only used one decision variable, which is video minutes. We have completed the super health study as well, much like the team study I presented. We actually have now looked at uh, the data same approach, applying machine learning techniques using variable data. Over here, we also collected some variable data using Fitbit. So we have a lot more data, and now we are using this to build, an approach where you can use the pragmatic trial data plus machine learning algorithm to come up with decision rules that are not only focused on one specific uh, clinical criteria, rather a predictive algorithm which which accounts for multiple variables that have been there. So uh, going back to this figure that we had, that we were able to build an algorithm based on the trial data we have collected. Now we are quite literally building a infrastructure to incorporate these things in a next study that has got funded through a RegTech center that's funded by Neidler. There's a project, and we are incorporating this approach where we are not going to limit ourselves to only one tailoring variable, but really a composite based on a predictive algorithm. And then and that involves also setting up infrastructure to implement this decision making in real time. Because in these smart trials, when participants are asked to complete either surveys or measures, or uh, based on certain values at a given point, let's say 3 months, they will get re-randomized, and that in many of these studies needs to happen at real time, which means that we have to make we have to the not only run that algorithm, but then there's also the randomization piece that happens, and the randomization information then needs to go back to the investigator team for them to be able to uh, move forward with the trial. So I think just using machine learning to enhance the smart trial preparatory phase, and also like building infrastructure to incorporate that in a very research trial setting is sort of exciting, and we are doing that right now. So the other study I would mention is GODART, where it stands for gamified optimized diabetes management with artificial intelligence powered rural telehealth. It's always good to have these names. Uh, my colleague and close collaborator Mohan and I have Dr. Thirumalai. We have developed this project. It's funded by NIDDK, and the idea is to have a cost-effective, scalable diabetes management program that can really assist or augment primary care with population health management. And the idea here is to really utilize AI uh, to help with lifestyle modification intervention. So again, to give you a context, within family medicine, we have a nutritionist, Dr. Caroline Cohen, amazing. She has one more person in her team. But if we want to scale this across our patient population and be able to provide them that support, there's just not enough bandwidth to do that. So the idea is to really see, can we bring an AI-based approach to lifestyle modification to help with glycemic control, and also gamification to support engagement and adherence, which is one of the key areas that we have found, uh, uh, you know, in the success. Like engagement and adherence is important for any program to really be effective over time, which is why direct cam did not with the effects of direct cam shrunk, because the engagement and adherence stopped after 3 months. And this also builds on on our team's work, where we have used IVR. This is also using IVR uh, approach to actually collect data and do automated behavior monitoring. So we will have automated behavior monitoring for every day for these participants, and we are trying to build a package which is looking at a technology optimization piece, which is like human versus AI powered telecoaching, and gamification, that is fixed versus adaptive gamified rewards, which is a resource optimization piece. The AI piece over here comes in terms of using the NutritionX API that has been embedded within the Godot platform. And this helps collect that data and then make decisions around what the coaching responses need to be based on the input provided by the participants. The participants receive calls every day. They answer questions about their medication, health behavior, including food and exercise. And then we are using this to really, automate what the response would be to the participants from a health coaching point of view. Uh, we are implementing this right now. The study is ongoing, very much ongoing. Completed the usability testing, and sort of excited to see where this goes. Hopefully, where I want this to go, and it would go in a direction of really having this platform as a way to engage with the medical team and using AI-based approaches to expand behavioral health coaching for chronic disease management across the state. And that's really where the focus of this project is. So moving on, I will share a few activities we are doing, again with this focus on quintuple aim, but really people with disabilities, physical disabilities, of how our data coordinating center within NICPAD is really trying to achieve that goal. So within NICPAD, we have three strategies. We have the health. This is a CDC funded project. So we have been tasked with three strategies. One is, enhance health screening and referral of people with disabilities, provide health promotion programs, primarily telehealth based health promotion programs for people with physical disabilities, and then capacity building, that is increasing the referral of people with physical disability to NICPAD, but also sort of training uh, primary care providers and other healthcare teams in making the healthcare more inclusive for people with disabilities. The data coordinating center largely focuses on the strategy one and strategy two, and our outcomes are, to track and really help increase health screening for people with disabilities, adoption of healthy lifestyle behavior, uh, increased awareness and management of chronic disease, and then improve life satisfactory and emotional support. From strategy two point of view, which is on health promotion, really looking at the effectiveness of those programs, both immediate and sustained, the reach of those programs, and then whether that translates into improved quality of life. So within the data coordinating center and NICPAD, we have also an evaluation and performance measurement component. So what the typical workflow is that the capacity building team reaches out to healthcare providers, encouraging them to refer patients to NICPAD Connect, which is our registry that we have developed. The NICPAD Connect information then helps our healthcare inclusion specialist invite and refer patients to our primary program, mentor program, which is almost think about it like trying to build resilience and mindfulness before they get into any disease specific chronic disease specific programs. So that 8-week mentor program can be followed by different specialty programs around diabetes or obesity or even mental health. And that information is then tracked back. We provide that information to our partners, our healthcare providers, so that they know how, what the patients, how their patients are doing, our NICPAD participants members are doing. Again, NICPAD Connect looks at longitudinal surveys based on PROs that have been identified from national surveys of NHANES and BOFUS. We are doing comparison of our participant data with national data sets such as NHANES, BOFUS, and NHIS. Also assessing the benefit of the health promotion programs by looking at quasi-experimental designs that we could be applied, and just highlighting the team members who have really NICPAD data coordinating center team members who are really working here. Navneet, Baidwan, Salma, they've also done some incredible work in the Teams study for us. I think one of the exciting part over here within NICPAD is that we have partnered with Health Choice Network, which is a federally qualified health center. It's a health centered controlled network of federally qualified health centers. Has about 200 clinics, presence in 9 states. And the idea here is to really, Health Choice Network provides EMR support to all of these federally qualified health centers. So what we have done is we have really embedded in their EMR a 2-item screener at point of care. And we are working with some clinics more intensively to have the referrals done to us through their EMR. And with others, it's more of an educational and outreach approach to say, hey, do this. And 2 things, we can A, compare these 2 approaches. B, I think this is embedded within the EMR, that the EMR is, across all these FQHCs. And this is an example of the items that we have programmed for just sending referrals to us. It's like we can now, in addition to our NICPAD Connect data, we also now are able to track their labs, their demographics, So again, looking at our immediate benefit of what we are collecting, but also looking at patient encounter data from Health Choice Network. So it gives a nice closed system for us to track how our NICPAD Connect members are doing, and also like who is joining from this patient population, who is not joining, evaluating those things further is sort of important for us. So we are using the electronic medical record data feed to look at the reach, the effectiveness, both from a clinical point of view, because that data can be tracked through their EMR feed, adoption, how many clinics, which providers are really sending the referrals. And then my colleague Larry Herald and others are doing some interviews to sort of understand implementation and maintenance. And we want to grow the space out of even qualitative interviews, trying to be innovative over there, looking at ways of using AI-based qualitative approaches to, not really traditionally restrict to 10, 15 interviews, but really do it at a large scale. So I think we are trying to build that piece out, and sort of very exciting time to be in this area. Constantly improving and looking at innovating our data coordinating infrastructure. I think we are in an amazing era of sort of AI technology just coming through. So to me, we are investing and looking at what can we bring to increase the reach and make some of these technologies available to NICPAD members. This is the current reach we have of the members, NICPAD Connect members, and you can see like this is comparing the population with disability at each state versus what we are seeing in our population. So we started enrolling last year. and growing further. We have more than 932. This is a little bit older slide, but I think you get the point of like this is the evaluation is important for us to really understand how our center is doing. To increase the reach and engagement, one of the things we are going to do is use coaching calls. So our NICPAD Connect call center has calls with our participants. We are now building infrastructure to use coaching call teams to use large language modeling to really predict which of these members would require additional help. And I think that's something that we weren't thinking about when we started this data coordinating center 2 years ago, but clearly we are now very much in that space. We have with the advance of large language modeling, I think that's something we could do, and then also bring our text messaging and IVR based approaches over here. In the team study, I mentioned to you about a rule-based approach to provide feedback. In Godard, we are using AI-based approach for IVR, and the idea now here is to really, from an implementation science point of view, really use the AI-based approach to increase the reach through text message and IVR, but also sort of engagement, do that engagement through that. So we use Twilio and really building upon what we have done in the past, but sort of innovating in this space further. The other piece is the remote data collection piece that we have implemented actually for an international weight control registry, but we are using Validic platform and again implementing this for NICPAD. The nice thing about doing this is like we have the ability to have bring your own wearable devices option over here because we work with Validic, which is a company that sort of standardizes the data stream from different companies of wearable devices, and it provides us a large menu of options for our participants to use. And this again allows us to track not just patient reported, but remote data collection at home. And then from the health choice network, electronic medical records I mentioned to you about, their patient encounter data. So now we are starting to combine these different data streams that would be extremely helpful for us. I think the final few minutes I would like to talk about the most exciting project from a health system point of view. I feel from a research point of view, innovation point of view, that has enhanced, and I wanted to thank the Jorge Alip and Benjamin Willett and a lot of primary care physicians who have been pushing this and leading this for us. So the why part of this is that patient portal messages have become a burden for our primary care workforce. And at UAB, there has been an over 60% increase in portal messages, and this is sort of a national trend. Patient portal has been advocated a lot, but like how that should be used, and the infrastructure of around it has been pretty weak and causing physician burnout. So what we have started doing is, so overall goal is to reduce provider burden of patient portal. And this is important, especially with the shortage we have in primary care workforce. So the first phase was to just design categories for patients to self-select while submitting messages. Some institutions, not UAB, but some institutions have also tried, piloted, then went back, but they were trying to even charge for patient portal messages. Our approach is to actually bring AI to help in operationally, processing these messages into predefined categories that physician leads have identified, followed by converting these certain group of patient messages into billable telehealth visits, and then uh, you know then almost the next phase of this very last phase, I hope soon, but I think it will take at least a couple of months, would be to then have AI based responses to certain patient messages that are of certain categories. So I think that's uh, going to be important. This is some ongoing work that we have done. Uh, Dr. Delaney and Dr. Hennessy have been leading this work in terms of creating the gold standard data. We are using large language modeling to use them, refine based on these categories to, classify patient portal messages further. What we found was that just between these two physician leads, there was moderate agreement but not strong agreement. So there is some refining of categories that is being done further, and followed by sort of going back to training the model and using large language modeling to classify these categories based on what our experts have identified as gold standard. And the overall goal approach would be to uh, really then have a conversational AI approach to allow patient portal to become a much more uh, engaged platform, uh, and help providers prioritize messages and not get bogged down by sort of messages that do not add value. So that's that's a project. It's a practice transformation innovation project from a health system point of view, not a research study per se. That's ongoing. So in summary, I believe like bringing pragmatic digital and adaptive interventions with population health programs can really help with quintuple aim. We do want to think about how do we optimize this from a clinical perspective and utilize machine learning techniques to build adaptive interventions and AI to really also deliver interventions itself. Uh, and I think clearly AI has a lot of potential for operational efficiency in primary care. We are just getting started. A lot to catch up in this area for us. So welcome any collaborations, any interest folks have over here. Thanks a lot. Yeah.
All right. Well, thank you, Dr. Mehta. I mean, this is certainly very eye-opening for bioinformatician to see how AI is transforming you can call it the digital health uh, ecosystem. One question I will start with is related to the role of AI. You showed many examples, and many of them I think are just really to offload the physician's tedious work, which AI probably can do very well in
Mhm.
terms of efficiency. But do you also see areas where AI can be better and inform and coach physicians? Do you see that potentially playing a role in the future, slightly different direction?
Yeah, I think it there is uh, definitely potential for that, and I know in some of the talks, for example, that Dr. Ruben Pillay has given, he has actually some examples of uh, companies that are already doing building on in that space. So I think there is definitely potential, and we could do that. I'm more realistic. I want to get to some pain points of what our providers really have, how our health system at the speed at which we can work here. But yeah, there is opportunity to do that. There is opportunity to bring AI-based clinics to offer after hours appointments that could be done. So those are some, and learning from those, how do you further enhance the guidance you give to patients, and shared decision making could be done. I think I have broad ideas, but I don't have a specific you know projects right now in that area. Yeah.
Right. We have a question from John.
Sure. Yeah.
Yeah, I was wondering if you could say a little bit more about how you're using those large language models in the patient portal, like specifically what kind of agreement were you actually measuring there when you showed those CAPA scores, and what kind of training you were talking about for the model.
Yeah. So John, we have just started doing that. The model my data scientist has used is a large language model from Meta, and I can share the more details with you around that. But that is what we did was we used the categories to further refine or sort of improve the precision of that model. Now, the inter-rater reliability that I mentioned actually was inter-rater reliability between two physicians classifying the same messages. So there's sort of two streams going on here. One is there is the gold standard data set being created, as you know, and you're very familiar with that. And then simultaneously, we were trying to see, can we also start, just building some initial modeling work around that. So that's as far as we are around that. And in fact, what we did find was like there was like from 7 categories, we are reducing the class categories to 5 categories that would be done. So there's some gold standard data that would be redone around that. That hasn't been completed yet. Yeah. And the number of messages that we'll want to do has over 2,000. We did this for about 250, 270 messages, got some early understanding of the reliability, and then move forward. But the model that is the Llama model from Meta, as I recall. Yeah.
Thank you.
So we also want to give opportunity to gyms and people in the actual room.
I have a question. I mean, it's a really impressive span of work. Lots of different projects. It's really a little overwhelming to try to think about how we would actually bring all those to bear in one system. And I wonder if you've thought it, I mean, when you look at each of them is sort of like, here's an intervention. Let's figure out which patient population it's appropriate for. Let's get some information about the individual so we can tailor the intervention. Then let's administer the intervention, and then let's collect outcomes. So there's kind of these 5. Was that your quintuple? I never saw what the 5 things were in the quintuple, but there's 5 things. Can you think about a framework in which you could sort of generalize about those 5 things so that when you come up with the next thing, the next AI tool or based intervention, you could integrate it into that infrastructure without having to create a whole new project? Not necessarily for the research phase, although that would be interesting to think about too, but this is all about learning health systems, and actually we want, these aren't just academic exercises. We want to actually take these interventions and improve people's health with them, not just study subjects, right? So we want to find a way to bring them back to the point of care. How do we do that in a way that we don't have to invent a whole new project every time we want to do it, teach physicians and nurses and others and therapists what's available, and sort of start over every time, but instead go, oh, look, today there's a new thing on the list, and your patient has these, is qualified for this extra intervention, and here's how you would do, you know what I mean? So think about, what's a general structure that we could use to bring these kinds of things to bear, and then more as people come up with them.
Yeah, so I think I would answer this in 2 ways. So first, before that, I would just say that the quintuple aim, so if I sort of did not clarify that, around that all of these projects are focused on health equity with the idea of, reducing provider burden, but improving population health and patient experience. So I think that's, to me, bringing it is important. I think for us, at least from the disability point of view, building this infrastructure, and that's what I was alluding to in a center like NICPAD, and then building a partnership, which is a CDC funded center, but then building partnership with health systems across the nation where we can deliver these programs, not in a research way, like these are public health programs, but really incorporate them and continuously improve them based on the data we collect is going to be important and critical. I mean, that's critical for the success of CDC funded program, but it sort of translates all these work into action. For some of the other work, I believe like we need to work with digital medicine groups within health systems to incorporate this work. I think you and I would, like that would require more. It's not just about technology. It requires a lot more about, social aspects of like what, there'll be things that would need to be approved. And from us, from a primary care point of view, we have the Alabama Practice-Based Research Network, which is a network of practices across the state. And we plan to offer these digital health programming things that like the Godard piece I mentioned, even the teams-based approach through those, because that's something we can do at our end and work with clinics across the state, which is what we did in the team study. We worked with 43 clinics across the state, and that would, I think the gap right now where I don't think I have a clear solution. I welcome any thoughts you have, but how do you provide that input, whatever programming is done, like how do you provide the outcomes back in the EMR? How do you really, so that the providers can see how those are being done? That's a bottleneck right now. But otherwise, we plan to have these delivered either through NICPAD for people with disabilities and for diabetes one through our Alabama Practice-Based Research Network.
Well,
Thank you.
yeah, thank you very much. It seems that the stitched photo or videos from the on-site and the interaction between online and in persons work very well. So I'm very happy that this experiment is successful. But of course, we want to thank Professor Mehta for the wonderful presentation. There were a few advertisements about annual symposium and next week's event posted in the chat box. Pay attention to emails coming up next. Thank you.
Yes.
Thank you, Dr.
Dr.
Yeah, please let
Thank
me
you
know.
very much.
Yeah, thank you.
I really appreciate it. And yes, we have our symposium 9:30 a.m. on Monday. We'll have better refreshments. So we do encourage people to attend in person. Dr. Agarwal will be doing a welcome, and we'll be giving an overview of the new Department of Biomedical Informatics and Data Science. So yeah, stay tuned for that. And then we will be having a Power Talk next week, same time. Also the hybrid, like this one with Shelby and online. So again, thank you, Dr. Mehta. Really appreciate your contribution.
Thank you, Dr. Smith.
Bye, everyone. Have a nice weekend.